Hey, folks, welcome back to another episode of the Change Physician Podcast. This is your host, Dr. Kevin Cuccaro, and I'm here today with my co-host, Dr. Melissa Cady. And our guest is a very special guest for a number of different reasons, which I hope we get to go into. But this is Dr. Josh Umber. Dr. Umber is one of the trailblazers when it comes to direct primary care practice, entered into that field very early on, and has an amazing story, which we're really privileged to be able to have him tell you today. So Dr. Umbers, thank you so much for joining us on The Change Physician.
Yeah, excited to be here. Thank you very much.
All right, so we're going to start really early on and ask you the question of, why did you actually decide to go into medical school?
Yeah, medical school, I guess itself, growing up, my dad was a trash man. He's a lawyer now, so I still tell people he's a trash man. It's much less embarrassing. He's actually our lawyer, so that makes it even better. But we would be on the back of that trash truck every summer, and he said, "Look, you can work with your back or your mind. It's whatever you want to do." So we learned early on the value of education, and then I'd always been interested in sports and anatomy and things like that. And then my undergrad was in nutrition, so it was a natural to get interested in pre-med and from there, it's easy path to wanting to be a physician, I think.
So you go in, you're like, I'm going to use my brain. You have all this kind of background information on nutrition and the body and things. But as you enter medical school, how did that change or influence your decision? What did you discover in medical school? Did it confirm your reason to go into medicine, or did it sort of add a different dimension?
I don't think I questioned the med school part, but even as a pre-med, my initial exposure to like insurance billing was working for a plastic surgeon. He was fresh out of residency, absolutely brilliant cutter, but struggled to bill insurance, and probably because he hired me to bill his insurance. They don't teach you how to code, they don't teach you how to run a practice, and this is 2000. But my dad's business, in hindsight, was a membership model. You paid once a month, and we picked up once a week. Watching the sausage get made for this plastic surgery clinic, where he could do 5-6 hour surgeries and be paid $200 from insurance because he didn't know what modifier to use, or our HCFA 1500 form printed out on a laser printer, got off just a little bit. And, we're not going to pay you. You can resubmit it and try again. And kind of just leveraging bureaucracy against a small clinic. And it really shattered that notion that we had growing up of, if you just work really hard and you're good at what you do, you'll be fairly compensated. The money side will take care of itself. And that was the Emperor's New Clothes moment, where it won't. Insurance is a game, and it doesn't matter if you're a surgeon, you've got to play that game. So being able to step into that world with a viewpoint from how business can and should work made that very obvious. So all through undergrad and med school residency, I was looking for doctors who were doing things different, and was very fortunate.
All right. So we're talking before we had that little technical issue is you were seeing a problem actually with the payment and billing model of medicine from a business perspective before you even entered medical school. Was I correct on that?
Yeah. Working for the plastic surgeon and trying to learn billing and coding, HCFA forms, modifiers, and realizing your reimbursement was based more on your ability to play the paperwork game than your quality as a surgeon.
So, that started before medical school. Did that still percolate in your brain then while you were trying to shove it full of biochemistry and everything else that's involved?
Yeah, it was so great. My earliest mentor was Dr. Vern out of Portland, Washington, or Oregon. And he did Simple Care. And this is like 2001, 2002. He had a PowerPoint on his website, which showed that over the past several years, he was losing money on 4 out of the 5 insurance companies he worked with. So he said, "That's it. I'm out. I'm going to charge simple prices." I think it was 50, 100, 150, based on complexity of the visit. And he was kind enough to answer every email I sent him. And I would have these ideas, and I would mention them to med school professors in different classes. And they say, "Oh, no, that's crazy. You can't do that." then I'd email him and be like, no, they're crazy. You absolutely can. And I'd just go back and forth and learn, watch what other practices did and if it worked or not. So even though I was the kind of token evil Republican or capitalist all through med school, when people got frustrated or had questions or wanted to explore something, they knew that they could, have a study break with me and pick my brain or see what I was talking about. And, because as you go through med school and you see all of that sausage getting made, even the students were realizing that this is broken, and they were interested in any voice that might propose an alternative.
So before I'm going to steal it from Melissa. I know she wants to ask something.
Keep rolling.
But I have to, because this is really interesting perspective to me. And so then when you're in medical school, you're already seeing that sort of the business of medicine, there's major flaws in it. Did that then influence your choice of specialty training or your residency that you went to, or was that something else?
I think my grades limited that more than anything. I was probably never going to be anesthesiology, but no, I always wanted to be either peds or family. One, I like a broad skill set, but two, looking at from a business standpoint, I knew that was the greatest opportunity to have a broad swath of value.
Awesome.
That's
all right,
great.
Melissa, I just told so many.
Is it my turn? Well, I mean, a lot of this is, it seems like you have a kind of a crystal clear, despite trying to figure out the nuances of how to create things. I guess the question is, the people along the way through the medical school and your residency, did some people like kind of, they didn't want to like really believe that the realities of, the insurance world, were they just so overwhelmed themselves that they was just beyond their bandwidth to like sit there and try to understand that or consider something that's an alternative?
I think it was definitely that in terms of bandwidth. Didn't feel like they were knowledgeable enough about the workings, business, medicine, politics. And I think the easiest route, especially in med school, is just universal healthcare. And I think you're high on passion and low on experience in med school, and the rest of the system wants you to go that way. So even though it may not sound like it works, it's just an easy answer. Because I think the fallacy is, well, people with great insurance are easier to take care of because you just run into fewer roadblocks. They pay for meds, they pay for labs, they pay for testing. So that must mean the best solution is to give everyone the most expensive insurance. It's a sledgehammer in terms of a solution. And I think one of the things I've learned in this process is our fault as professionals is that we don't read outside of our scope. Teachers learned long ago that pay for performance doesn't work. Silicon Valley's learned to embrace failure, fail early, fail fast, fail often. And we have a moral objection to adopting business into medicine. The much easier path is to say, well, I'm not in it for the money, so I'll just ignore that. Now, when I go to take a job, I'm looking for the most money I can. My med school professors don't work for free. Everybody wants to get paid in the system, but they want the system to be universally covered, because that's what everyone else does. And I think that's just a very academically weak argument. So, all the popular kids have universal health care, so we should too. But then you dive into that and realize it doesn't work for other countries. And so I'll often have this debate with med students. It's okay, which country do you want to copy? And they have a very limited view. They think Canada and the UK are even in the top 10. And Sean Flynn is a economics professor and author, and he's done a book on this. The UK and Canada aren't even in the top 10 in terms of universal health systems, in terms of cost effectiveness for years of life gain. Canadians have to have private health insurance for prescriptions if they're not in the hospital or they're not sick or poor or old or poor. So we just are completely unaware of how other systems work. We just default to that option. And when you say, okay, but there could be a better way. If you could make medicines cheaper, then you don't need the government to pay for them. Would that be good? Well, yeah, but the emperor's new clothes, the questions we haven't learned to ask, we haven't learned to innovate outside of our space. I literally had professors, Dr. Marcy, PhD, not MD, who we did the social basis medical practice, which we abbreviated to speed bump, who worked with Hillary in the 90s on universal health care, which is, good for her, but she brought that attitude back and there was no room for debate. You were a bad student if you disagreed on that. And that was vocally expressed. That wasn't even implied. Money is bad, business is bad. It's unbecoming and unprofessional of a physician to address these issues. So they teach from a point of fear that there is no other solution. You have to adopt this. And so most of us do. I obviously rejected that concept in large part because of reading Atlas Shrugged and understanding that we can proudly innovate and adopt these business things. That if I can make medicine cheaper, that you don't need health insurance for it, then we solved a couple of problems. And just even exploring any kind of business model that gives us authority.
Yeah.
I find it very interesting that doctors will constantly complain that insurance and the government have created a bad healthcare system. But then when you ask them how to fix it, they immediately turn and ask, insurance and government to fix it. It's very much learned helplessness and herd mentality. We don't actually foster innovation from within, and then we wonder why we're stuck where we're at.
Yeah. I know we're going to go back to your journey here, but you brought up a topic that I think is interesting, this whole aspect of a dependence, a learned helplessness in a sense that we're not able to help ourselves, especially come together and make better solutions. But there's always these third parties, and there's going to be third party interests, and it's going to be not serving, the two people involved, the physician and the patient, very well. I guess, what is your feeling about, it almost seems as if each individual, it's almost like we have to collaborate in a way to build the belief that we all can do kind of, what we're going to talk about later is just building a direct primary care practice so that you can, the problem is the other people out there are not going to benefit.
Right.
So how do you they're not going to really rally behind you on that. It's going to be more the people that are loving what's happening. It's going to be a grassroots effort. That's how I see it. Any thoughts on that?
Yeah, I think that's absolutely right, and absolutely the status quo for any other industry. Hilton wasn't trying to help Airbnb. Taxi services actively fought against Uber. AOL came out of Wichita, where we're based, but was technically illegal when it started. And that's the problem with not kind of reading either business or business history, tech history, these things. You start to realize that most of these things that we just take for granted now were on the bleeding edge of their time. For example, when Google offered unlimited email storage, they actually got called before Congress because people were so adverse to this idea. It's like, no, we probably remember, but our students don't. The days of your inbox is full, you can't get any more email. And so you had to delete things. So things just disappeared and they were gone. And this idea that you might save things forever scared Congress to the point of giving subpoena to the Google guys, and now we want everything in the cloud. That there's a proud tradition of doctors who are innovating in their space, and we can innovate anywhere else. If you're a surgeon and you make a better tool, God bless you for it, because insurance doesn't care. We've got every retractor known to man, and when those don't work, we have malleable retractors, and when those don't work, we have med students. So surgeons have always been innovators, oncologists, chemotherapy, all these kind of things that were just an idea at some point we push through. But the moment it comes to the idea of the business of healthcare, the delivery of healthcare, we shut our brains off and we abdicate all authority over to someone else. And the problem with that is if we don't what I'll normally say is I blame doctors way more than I blame insurance companies, because insurance companies are just a payment model. They're not licensed professionals. They don't practice medicine. How could they tell us how to invent a better system? That's our job. That's our responsibility. And the only way that does happen is a grassroots movement saying, what is the problem I want to solve for my patients? Whether that's, eliminating copays or making procedures cheap, but you have to have this idea that it's even possible. We go into this and then we don't challenge any of this, the kind of the sacred cows of the profession. Oh, meds are expensive. You get those through insurance. Why? Well, why are they expensive? Well, I don't know. Well, who do they buy them from? I don't know. Well, how much do they cost them? I don't know. And I don't want to know, because again, the business of medicine is bad, and we've seen bad examples of that. So I'll stay in the middle of the herd and just complain about it like the rest of the herd, rather than approach this in a very specific way.
Yeah. Go ahead, Kevin. I know you're just.
Well, because I think there's a couple points there. The first one is this idea that business is hard, business is hard, but I should say that we shouldn't be interested in business, right? And I 100% agree that we as a community have done this disservice where we've stuck our heads in the sand and decided not to address it in any way, shape, or form, or for some reason believe that it's somehow harder to learn than biochemistry or anatomy or surgery or anything that we already do. The other part about that, though, that I think is really important is as we've been with these third parties, the value exchange has changed. And so I want to return it back to your kind of story, because what you've done with the direct primary care model is you've returned the value exchange between the two most important people: the deliverer of the service, i.e. you, the physician, and the recipient. And people sometimes hate the word of talking about patients as customers, but they're a customer. They're the receiver of the service. And when you have now returned that value exchange in that way, now you can have a fair exchange of value, and you can actually monitor and deliver the goods and services that are beneficial. And I think that sometimes gets missed in these conversations, because physicians talk about third-party payers or talk about universal health care. And I'm not saying I am for or against. I think there's different tiers and models that can be used for some of these things. But what I am saying is that it's important to understand that when you have a value exchange that is so twisted and torqued in our current system, where you have patients paying ungodly premiums to an insurance company, the insurance company is now reimbursing the physician or hospital system, and then the physician or hospital system is then delivering a service to the patient individual. In that sort of triangle, it is very difficult to have useful information about what is valuable and what is an effective kind of value sharing relationship. So that's a long way to say is what I love about direct primary care, and I love what you guys have done, is you've returned that relationship in such a way where we can call competition. We can say it's about value added servicing. It becomes much easier for someone who's an enrollee in your clinic to say, look what I'm getting for my monthly membership fee, rather than complaining about these huge insurance policies and then go into their doctor's office and get mad when the doctor says, you're going to be okay. You just need some chicken soup. And they say, what are you telling me, chicken soup? I pay $1,500 a month for this. You better give me something for this.
No, it is. You're right. It's a sort of a bad, self-fulfilling prophecy, where the doctor gets paid more if they have higher complexity of medical decision making. So they write a prescription, regardless if the patient goes and gets it, they're paid more for it. So even a good doctor is disincentivized to make things sound more complicated or write a prescription when they don't necessarily need it. And that's not to say all doctors are bad or all scripts are bad. It's an inherent flaw in the system. The incentives aren't aligned, but this is the problem you have anytime you have unnecessary pieces in this machine. You take, again, Silicon Valley, there's so much to learn just because there's so much innovation there. The whole point is to make things faster, simpler, easier. Google made searching things easier. Peter Thiel, one of the founders of PayPal, was asked, well, can you predict the next big thing? He said, of course not, but I can predict what won't change. And people will always want a better service at a better price, faster and easier. If you apply that metric to shopping for a hotel room, you get Airbnb. If you apply that to finding new products, you get Kickstarter. Finding a taxi, you get Uber. If you apply that to healthcare, you say, well, what can we remove from this? And we can remove all the things we actually hate in medicine. We hate seeing 30 people a day. We hate feeling rushed. We hate being on the phone with insurance for medicines. We don't like being told that we can't order labs because the insurance won't cover it. And if we dive in and challenge those assumptions, we realize that I can see a fraction of as many patients per day. I can see them for 30 to 60 minutes at each appointment if I want. Now, if I'm not asking insurance to pay for it, then I can have a very simple note, just what matters. When medications and labs wholesale are up to 95% less than the patient can afford it, and you can give it to them right there, now you start realizing what middlemen add value and what middlemen don't. And it doesn't take a rocket scientist to say, cut the fat, cut the things that don't matter. If the third-party payer system works so well, we would see that at the grocery store. We'd see it at the gas pump. We'd have Netflix insurance. Point is, it doesn't work well because, not to give insurance some slack here, is because it's not insurance. Warren Buffett got rich because he had a very technical understanding about what insurance is, and it's the term between pay in and pay out. Life insurance isn't even a risk. We know you're going to die. The only question is when, and statistically with any large sample size, it's going to be a long time. So I can start selling you insurance here and take money for 40 years before I have to do a payout, and makes for an easy process. In healthcare, we have insurance that people will use the very first day they get their card, and they're disincentivized to care about the price. They have a $10 copay for generics and a $20 copay for name brand medicines, and no one can tell them that name brand Lexapro is $13 a pill and generic Lexapro is 4 cents a pill. And when if it's their dollars, they want the cheap thing, the most cost-effective thing. But like you alluded to, well, if I've already paid this much for health insurance, let me pay $10 more to get the expensive thing, not knowing that that expensive thing is why your insurance goes up next year, is because you got $300 more worth of value each month than you needed. So if we back this off, the same reason car insurance, every other commercial is 15 minutes can save you 15%. They know that they can sell you the very high value, very cost effective care if it's designed right. But so we don't even really have insurance in healthcare. And again, I blame the doctors. So bringing that information back, that business model design, and some a heavy focus on value add, really just it flips the whole thing on its head.
Yeah, that's everyone needs to hear this. So curious, your on-ramp, you're in your training, you already know, you talk to people, some people are ready to hear it, some people can't. I mean, they just got too much going on. But when did your on-ramp to your private practice start? When did you start putting the pieces together? How'd that happen? Do you mind going through that process?
Yeah, I've been putting it together even late med school, at least in rough design, but really started funding it in second year when I could start moonlighting. I moonlighted way more than my program director knew about. And I hate paying taxes, so I could put it all into the business, and I love working. So it was easy to say, okay, here's what we're going to do, and we're really going to dive into it. And run the math and say, we want, because at this time it's 2009, basically, maybe early 8. And the only real idea is concierge medicine. There is no direct primary care, but we knew we wanted to be an affordable version of concierge medicine. So running the math to say, what is the lowest price that we can offer to patients and still make a better than average income? But I also knew that nobody wanted to go to a cash doctor, because that it's just not, it's like gourmet coffee. You want roasted coffee, not warm coffee. So we wanted to build out a very nice location that I wanted to go, would enjoy going to, but that everyone, rich or poor, would enjoy. In part because this was such a new model, you really had to kind of punch above your weight class and let them know that, nope, it's a very nice looking facility. It's, in a good part of town. Because what we saw was this sort of roller coaster of, concierge medicine sounds great. It's very interesting. It's getting a patient to look at your value is very subjective. Well, what school did you go to? What were your grades? All these things. But if they heard concierge medicine, they assumed it must be good care. But they also, because you don't go to a Holiday Inn and expect a concierge, you go to the Four Seasons and expect a concierge. But they also assumed that would be high price. Well, that's easy because that's objective. And we could list our prices and show, $10 for kids, $50 for most adults, very affordable. Well, then that makes it sound too cheap for what you expect to pay for high quality health care. So if we were in a van down by the river, they'd say, yeah, that's what you get for $10. Versus if we were in an established location, then it kind of all fit really well. Now, thankfully, I don't think a great office is an important part of a successful direct care practice, but it was very important for us. So we were building that. We were going to Chamber of Commerce. We were trying to, even before we had an address, start getting our name out there that something new was coming.
Wow. So when did you go to the Chamber of Commerce? At what point were you at in your training?
I'd sneak out during third year.
Third year of residency?
Of residency. Yeah. Okay. Instead of noon conferences, I'd go to, or Chamber of Commerce breakfast or whatever it was. And had business cards. And I think our earliest article would have been February of third year, but I had to sneak the photographer into the clinic because he wanted a picture, in an exam room. So then the faculty were a little surprised when it came out. But so we opened in September, but that article in February, that's how interested I think the media, but just the community was in having something new. They didn't expect Wichita to be able to get concierge medicine, let alone an exciting, affordable version of that.
You're kind of like a physician, politician, businessman rolled up in one.
Boy, I try to be.
That's interesting though. So you're in the middle of, now you're in residency, you're already starting to build this practice. So what was it those first couple of years then, when you are now can fully concentrate on developing this practice model with the marketing and everything else that comes behind it? What were those first couple of years like? Was it a struggle, or did you find that this was actually that people were gravitating to it more than you thought they would?
We definitely gravitated more than we expected, but of course we set our expectations very low. At the time, concierge medicine on the expensive version, the idea was that you'd grow at 0 to 5 patients per month. And we doing a much more affordable version, we did our original business plan at growing at 10 patients a month and hoping we would do better. But we ended up growing at about 30 patients a month. And my partner, Doug, and co-founder, he was a hospitalist at the time, so a week on, a week off, but he would spend his week offs helping to grow the practice. But we didn't know if it would be 10 patients a month and not need him for 3 years or what. But ended up at his next contract negotiation, which was 9 months after we launched, we had enough patients and enough growth that we were able to bring him on full time. And then about every 18 months, I just kept hiring my friends from residency. So that was great. Dr. Michael came on a few, 18 months later, and then Dr. Sean, Dr. Jared, and then we opened a second location. But so it was easy in the beginning because when you only have 30 patients, or growing that much a month, you probably see 1% of your patients per day. So 1 or 2 people, they just don't need you that much, but you have plenty of time. Of course, we'd never done this before, so everything took a little bit longer. We were trying to figure out, how to get sharp containers and biohazard, waste pickup and all the little things. We were handwriting prescription labels until we found out that was illegal. But we knew long before that it was a pain in the ass for sure. So it gave us plenty of time just to make mistakes and learn. And we almost bought like a metric ton of prescription bottles from China because we couldn't find another supplier, and then found one. So we could buy them at 300 at a time. So all these little things, but it was perfect because we didn't know how it was supposed to be done. We weren't committed to anything specific. I think Steve Jobs, in some way, his brilliance was just asking the right question, having the right goal in mind. Make a beautiful phone. Don't make the FCC happy. Don't make AT&T happy. Don't worry about what the manufacturing costs. Make art. And for us, that art was what adds value to the patient. And I remember struggling like with labs, like how do we get labs cheaper, and working on it. And then we call it pulling a Doug. He comes in, it's like, well, I'll just go down to the lab and ask. And sure enough, he goes down and, 10 minutes later, he's got an answer. And it was much simpler than we ever imagined. And that's sort of been the truism through all this. Meds were always cheap. Labs were always cheap. EKGs were always cheap. It's just you had to know where to buy them. But it wasn't a secret. You're going wholesale. 44 states allow physicians to dispense meds out of their office. We didn't have to invent that. That was just already there. It's just doctors weren't taking advantage of it. They didn't realize that there was an opportunity to get them cheaper. But because most of them never run a business. But my father-in-law worked for Cisco Food Services and helped set up restaurants. So I at least had some exposure to know that, there's a wholesale world for everything. Mm-hmm. And it's always much cheaper. So there has to be a wholesale world for medicines. Well, what do you charge for an EKG? I don't know. I don't want to charge. We don't charge for the coffee, and it's 70 cents a cup. Why do we charge for an EKG when it's 36 cents? All right, great. EKGs are free. And there was just no one telling us not to do that. Right. So it was the first year or so was a fantastically flexible learning opportunity to just keep carving away all the things that didn't add value.
Yeah, it makes you think about how when you go into medicine, that first day starting out with medical school, the unfortunate part about this is that people step on the treadmill and they just let it take them wherever it's going to take them. And there's probably a better metaphor than that. But if we would just be more intentional in trying to understand the inner workings of the business of medicine, like you guys figured out, it would be a whole new world. Go ahead and pull that song out in the background. But it really would. It would be totally different for everyone. We would be, I think, so much happier as clinicians. Patients, I mean, I think once, you probably can tell us, once people experience it, what is the potential, how many of them leave you, in all honesty?
First, I think
other than moving to another state.
Sure. In general, we lose about 1% of our patients for all reasons each month. So, 1%. Very small, whether it's lack of 1%. People, the bar for customer service is so low in healthcare. I really respect Jeff Bezos because, even 23 years later, he's still writing his letter to shareholders as our first focus must always be on the customer and being consumer obsessed. You can be product obsessed or competition obsessed or price obsessed. He pathologically consumer obsessed. And, you can learn that from an 8-hour book, the Everything Store about Jeff. So the fact that now you got to give med school a bit of slack in the sense that no other business school figured this out either, but no other business person has the access to things that we do. They couldn't sign up and see what wholesale meds were because you have to be a physician or a pharmacist. So getting on that treadmill and just saying, I'm going to do what everyone else does. And once I get this far into it, I'm sort of a good Stepford wife, right? You're a good little pre-med student, good little med student, good little intern, good little junior partner. And before you know it, you're 40 and you're just used to following rules. You don't question anything anymore. In fact, we beat the questioning out of them in 3rd and 4th year of med school. So we need to foster this idea that innovation is great. In the 90s, hacking was a horrible thing, right? And now Fortune 100 companies will have hackathons. What idea can you come up with that we couldn't come up with our own? Let's, hack growth for a business. So I think if we encouraged med schools and administrators who, to pay them at least a little respect, they don't know it because they've never done it. There's a great book, The Richest Man in Babylon, and his short fable, the rich old man gives young poor man advice. Poor young man tries, comes back and failed. He says, "What did I do wrong?" He said, "I told you to do a diamond deal with a diamond guy. You tried to do a diamond deal with a blacksmith." So asking our med school attendings to teach business innovation is just wrong because they're not in the world of business innovation. But that does say we need to bring people to med school that are in the business of this. So whether you innovate a better bit of code to connect with a digital scale to track pregnancy and then send a text message, that's all very easy. That's doable if we open up a culture of innovation. That there was an article years ago saying that Google is a brain sink. It's taking the best and brightest engineering minds and getting them to invent better ways for people to click mobile ads as opposed to do something else. And I think there's an analogy there with health insurance that the fact that we're spending 30 to 7% of our day doing paperwork for insurance means it's sucking all the good time out of our schedule where we could be focusing on patients and innovation and what's a better way to reach out to depressed patients or anxious patients or whatever. So if you remove all that wasted effort and teach students a culture of innovation, holy cow, I think it'd be amazing the problems we would solve and how quickly we would solve them. But we have to get to a point where we associate business with being good for patients. The old adage, you can't eat good and sleep good, that we can't be proud of our profit. That's a philosophical problem that is perpetuated by the med schools. It was by mine, versus I'm very proud of the 6-figure income I have because I know that I've made medicines 95% cheaper for patients. The value I have is because I brought them a greater value. I'm saving them more money than they're spending with me, which is why we lose so few. And that you save $100 a month for a rich person, that's nice. You save $100 a month for a poor person, that's days of labor back. You get them the Imitrex that is $100 at the pharmacy for $3 at the office. That's a change in their life. Nothing triggers a migraine like the stress of getting an ER bill to treat a migraine. It's $1,500 for an ER bill. That it's analogous to debtors' prisons, where poor people are subject to these astronomically high bills. But if you saved them $100 a month, they could save for college. They could save for getting out of debt and any number of things. So doctors have to I don't love the term, but social entrepreneurship, saying that there is when done right, this is problem solving at its finest. And Steve, what's the book? I Start With Why, and we have the best why in the world, our patients. So as long as we're innovating in ways to help them, we really can't go wrong.
Awesome.
There's
Kevin?
so much there to unpack that I don't think we'll be able to finish. But what I love though is we're talking about value, right? And I think one of the things physicians need to wrap their heads around is when value exchanges are aligned in a way that benefits the end user of whatever that product, solution, or service may be, then you should be proud, just like you said, to accept the value that you gain from that. Because if you're going off like you're doing and you're helping people, and I want to touch on this in just a second here, but where you're saving people a lot of money, and you're making money yourself, that's a win-win relationship. And for people who maybe listen to this, because we talked about concierge or whatever, I'm looking at your membership fees right now, and what I just want a quick question is, your membership fees, from my understanding, are inclusive. Does that mean that they pay an extra fee when they come in to see you, or are those visits all included in their membership fee?
No copays. All procedures are free, and then they get access to our meds and labs up to 95% savings. So basically, at our cost. Unlimited home visits, unlimited work visits, unlimited office visits, unlimited telemedicine.
So I'm going to read these off for people to hear this, because people are, I don't go see a doctor enough, or I don't need this, or I already have my insurance or Medicare, so why would I pay for anything else? Well, your fees are staggered. So kids between 0 and 19, $10 a month, all inclusive, like you said. Adults, 20 to 44-year-olds, $50 a month, all inclusive. Adults, 45 to 64, $75 a month, 65 plus $100 a month. That is cheaper for any of those people than a copay for one visit to see a physician. I mean, at least for a month-to-month value. And if you're someone who is you're advancing in your age, you may be over 60, and you're seeing a doctor 2 or 3 times a year, your membership fees alone are going to be absorbed just on what you're going to be paid for something for copays. And so it's always shocking to me, as soon as you talk about cash-based practices or direct care models, before people will even ask what that cost is, they'll say, well, I can't afford it. And I look at your value and I'm like, well, how could you not afford this?
Well, it's a common question, and there's the cost, but then there's the what I'd say is the price. What is the cost after the savings? Mm-hmm. And I would argue that adults at $100 per month are cheaper than kids at $10 a month, because there's medicine, one in particular Medicare doesn't cover. It can cost $66 per day at the pharmacy cash price that we get for 11 cents. Now that so now that medicine's Viagra. But in 3 or 4 pills, then you've covered the cost of your entire membership. And so because people say, well, Medicare covers all these things. Well, it doesn't cover that much. If you look at investment journals, they'll say that senior citizens should expect to spend between $4,000 and $6,000 out of pocket every year. That's built into your retirement calculations. So yes, we have a huge opportunity to save them money. But they want a doctor who will spend an hour with them, or text them, or a CBC costs us $1.50, we charge $1.70 for it. Damn capitalism. Everything's just marked up about 10%. Then at the end of the day, by the time just basic labs and even a few medicines, Walmart created the $4 a month list. We have the $4 a year list. Often the medicine it costs less than the postage to ship it to them. So we've now made it to the point that the postage is the most expensive part in the medication process. And that's proof of what I would say is a broken market. We told Walmart when their executives invited us out in 2012 that we out-Walmarted Walmart. And I've since learned you're not supposed to insult them. If, in a good economy, you have to be Amazon to get Amazon bulk discounts, right? You have to be Walmart to get that level of efficiency and savings. The fact that 2 doctors ordering wholesale meds with almost no bulk savings are able to get medicines. On average, if it's on the $4 a month list, it would cost us 13 cents a month. So just give or take the pill, call it 30 cents a month for 30 days. It's a fraction of what they charge, but they're buying it less than I am. They're buying in Walmart bulk, but they're selling it for more. So it doesn't matter what they buy it for. We can still sell it for less. We can hand it to the patient. They don't have to go to the store. And I actually like Walmart, or the Sam Walton version of Walmart, where they expect a 2 to 3% profit margin on everything except the pharmaceutical side. That's where they lost their founding principles, because, hey, rule number 1 of the rat race, we all just got to keep being a rat. So if CVS is going to mark up something 10,000%, we can. And it doesn't even matter on the med, Walgreens or CVS will happily mark up a seizure medicine 1,000, 2,000%. It'd be $100 at Walgreens that we can get for $1 a month. At least if, it's honor among thieves, sympathy among capitalists, something where you could give the seizure medicine for less. But this was years ago. We looked it up. The state of Kansas in their Medicaid program was paying $400 a month for generic seizure medicine that we could get for $12 a month. So this even works at the Medicaid level to say, why, is the state of Kansas giving $388 extra dollars to CVS every month that was supposed to be earmarked for an at-risk Medicaid patient when the true cost of that medicine is, just $12, especially where Kansas is like a lot of states where we have a waiting list for severely disabled kids. We won't let them on Medicare because they cost too much. Now, post-Obamacare, let's expand Medicaid, to 100, 150,000 working poor. I'm not saying that's wrong, but I'm saying it's inconsistent with the goals of both the left and the right. When the left says, let's take care of the poor people, great, let's do that. And the right says, it's our, faith-based obligation to do so. Great. Then let's actually take care of the 5,000 kids in Kansas who are so developmentally disabled that you won't let them get free care. That's a problem. So then that comes to doctors to say, how do we innovate in a way that can save $388 every month on that medication and countless others? Adult diapers, the state of Kansas will pay $54 a month for 30 that we could get for 7 cents each. So there has to be a mechanism in place. Healthcare is not expensive. The way we're doing healthcare is expensive. And that's what Sean Flynn's article is, that we could probably decrease the cost of healthcare in the US by 75%. Decrease administrative costs, decrease duplication, decrease some of these things, bring it back down, actually let the free market work. Then doctors can feel that they are very, very well aligned with their patients' needs, so that where the value to patients goes, so do the doctors.
Yeah. Wow, I've always liked this idea of direct primary care, and for years, and Kevin knows this, and we've struggled being pain specialists to find a model to kind of deliver. At least for me, I thought that I could do that, but then it's hard when we're trying to help people not have pain and they don't see a need to have a monthly fee. So besides primary care, do you think this is something that could work for some specialists?
Yeah, and we know it does. We've helped over 900 doctors and over 600 practices convert to direct care in the last few years. So we have peds endo, adult endo, neurology, of course, lots of internal medicine. Psych is a great one. Peds, women's health, OB, of course, family medicine. The question isn't whether it'll work, it's just what tweaks do you make to the model. And I kind of see it as a continuum from hopefully nobody needs or wants a membership radiologist or pathologist. That is the most incremental care, incidental care. So that fits very well to a fee for service. Dermatology might be the next major specialty to be a mix. There's plenty of chronic skin conditions where you could charge a membership for, and then plenty of fee for service type things that could be done. Swing closer to the middle, and you could have things like cardiology or ENT, where you have some chronic care, some consult, some testing, and a patient with a chronic heart condition, regardless of their age, would be perfect for a membership. And a patient who's just worried well and wants to make sure that their heart is healthy for exercise, that's great too. They might just need a one-time visit. Or a stress echo for $200 instead of $2,000 in the hospital, and that's wonderful. We can bring the cost of these things way down. Then the far side of the spectrum is just anything that's chronic care, and I think pain is chronic care. And the interesting question will be: do you price it higher because it's a specialty and it's more valuable, but you can see more patients? Do you price it lower because you don't need as many patients as a traditional system, overhead's less? We have one staff member per doctor, not 5 to 7. Would you give between primary care and specialty care, would there be discounts working together? Say, okay, well, you've already got your blood pressure and things managed, great. So it's only, now if the specialist doesn't have to get involved in those things, then wonderful. And there'll still be fee-for-service consults and different things. So I think we get typecasted as anti-insurance, but really we're pro-efficiency. I don't want car insurance. I do want life insurance. I don't want home insurance that covers gardening, but I do want home insurance that covers a fire. These are normal things. And people are like, oh, wow, you can't have direct care trauma. No one said that. Yeah, it's very incidental care. Insurance is wonderful for expensive but relatively rare things. And people are like, well, I don't use a doctor every month. Well, then why do you pay for health insurance every month?
That's right.
It's this. There's a great book, Predictably Irrational. We're predictably making a mistake in how we purchase health insurance. You couldn't sell car insurance to a person if you built it like healthcare. Like, well, you can only get 2 refills of gas a month, and you have to go to our participating gas stations, and you have to get pre-approval to go out of town because we don't pay for gasoline in Oklahoma. All these kind of craziness things. So, and the beautiful part about that is the insurance companies have told us that their profit margins are 4 times higher working with direct care clinics because we outcompete CVS and Walgreens and the lab, and we don't have a fraction of the paperwork, et cetera. So that means they can lower premiums, they can offer a higher value, they can waive deductibles for surgeries if you go to places like Surgery Center of Oklahoma. So now you can have, instead of a $15,000 per year insurance plan, you can have a $6,000 per year plan. You can have a fully funded HSA. And if you do need surgery and you go to a center of excellence, they'll waive your $5,000 deductible. What part of that's not fantastic insurance? We at some point equated cheap insurance with bad insurance. I know you're not supposed to buy the on sale diamond ring. I did. But you're not supposed to, right? Good things are supposed to be expensive. Well, that's irrational because we've learned that even, the cheap iPhone is a fantastic phone. So now we've hit this point where healthcare has become so expensive that even, patients, employers, insurance companies are looking for an alternative. And then it'd be like life insurance or car insurance, where it costs very little every year and you rarely file a claim, but when you need it, it's there.
Yeah.
No, absolutely. And I think we could talk to you for another couple hours, seriously, but we won't.
We don't have to book you again.
Yeah, but we may have to get beyond because there's been so many wonderful points of conversation that I think the physician community would benefit from. But we'll hold those. We'll respect your time here, and just thank you so much for coming on. I didn't even get to talk or even give you a chance to talk about how you guys then designed an EHR system for your practice that you've expanded to other people. And I'm assuming that EHR system, just based on the conversations that you had, actually probably provides benefit to the users rather than benefit only for billing. So, it's fantastic. So is there, if people were interested in this and they wanted to either get in contact with you or learn more about you, where would you recommend that they go?
For doctors or patients, they can go to our website, atlas.md. We do all the consulting for doctors for free. We've got checklists, starter packets. We even have a lawyer on retainer for free to answer doctors' questions about getting out of their current contract, setting up patient contracts, all sorts of things. But we have a blog and articles and news stories, videos, all kinds of things to educate people on what direct primary care is and how to do it.
And I'm going to let Melissa take this out, but I have to just say, I looked at what your starter package, and for free, you have things on there that I know people are charging over $2,000 for. So it is unbelievable. And if you have any interest at all in direct primary care, I'd highly recommend that you check out the website.
Yeah, I mean, incredible value all the way around for clinicians and your patients, and being innovative and very proactive from within your own training to put your little tentacles out into the community so that they almost think it's their idea by the time it actually shows up. So kudos to you for all that you've done and with intention. And I obviously believe that this is a grassroots thing that is going to grow. It's going to take time, but I think it's picking up some speed, and anyone that's listening, heed Kevin's advice on checking out all of his information at atlas.md, which I didn't even know you could do that, .md at the end. Yep. That's pretty cool. Fabulous. Learn something else. So anyway, for those that are joining us today, thank you. And we look forward to seeing you in the next episode. I am Dr. Melissa Cady, joined by my host, Dr. Kevin Cuccaro, and our wonderful guest, Dr. Josh Umber. Did I say that right?
Umber.
Like lumber. Yep. All right. Yep. Perfect. Thank you again.